vascular and endovascular surgeon at Harbor-UCLA Medical Center in Los Angeles. I'm here to discuss my plea for having on-site allografts and freezers at busy trauma centers. These are my relevant disclosures. Trauma activations and consequently vascular traumas have drastically risen this past year nationwide. These pose both limb and life-threatening situations, further complicated by contaminated fields. Timing and swift decision-making are key. Do we shunt? Do we ligate? Or do we repair and reconstruct the vessels? These are common questions that both trauma and vascular surgeons face daily. We know that in stable patients, it is optimal to reconstruct given the more favorable limb salvage and survival data associated with doing so. We are all aware of the current options, and autologous conduit remains king. While greater saphenous vein, femoral vein, and jugular vein are durable and likely the most resistant to infection, size mismatches and increased operative times for harvest and reconstruction remain obstacles in trauma cases. The increased operative times have further patient-related and system sequelae. While synthetic grafts are readily available, they are the most susceptible to infection and thrombosis. Finally, we have cryopreserved allografts. This conduit has historically been used in elective vascular surgery in contaminated or infected fields. Its availability minimizes the time needed for harvesting conduit from other sites, as well as the need for secondary surgical sites, minimizing operative times and potential complications. It can be size matched and modified to fit the patient's anatomy. It does, however, require a freezer on site to be pulled off the shelf. We will briefly discuss 3 scenarios where having cryopreserved allograft readily available from a freezer may have saved operative time or delays in care. The first case is of an 18-year-old male who was status post gunshot wound to the left leg with active hemorrhage. The patient was stabilized and taken to the operating room of the trauma team. They found an injury to the left common femoral vein as well as the saphenous vein and profunda artery. Given his stability and age, the trauma team called vascular surgery for immediate reconstruction. As the defect was lengthy, there was question as to how to repair this injury. A decision was then made to harvest the saphenous vein and spiral the graft. These are images of the spiraling process. In this case, we needed about 5 centimeters of greater saphenous vein to repair the defect. We chose a 28 French chest tube as this was the best size match for the common femoral vein. 5 times of the length of the defect were needed of the saphenous vein for creation of the conduit. This is obviously very time-consuming for both harvest and reconstruction. Here's the final product in situ after the repair. Postoperatively, the patient became tachycardic and was found to have a hematoma on exam. He was taken back to the operating room for exploration, and the graft was down due to compression. Removal of the hematoma allowed for filling of the conduit. The patient was seen once in follow-up without swelling. While this case ended up going well, it took much time to call in vascular surgery, harvest, and reconstruct the vein. The second case highlights the use of prosthetic. A 31-year-old female status post gunshot wound to the thigh and abdomen came in. The patient was found to have a bladder injury, as well as complete transection of the external iliac vein. Given that the patient was relatively stable and young, a decision was then made to repair the vein using a 12mm PTFE synthetic graft. While the operative time was limited, given the off-the-shelf option used here, the graft was found to be thrombosed on postoperative day 2. This is also a known contaminated field. Future infection of this graft remains an issue. The patient was likely a good candidate for the use of an allograft. The final case involves the use of shunts. A 25-year-old male status post gunshot wound to the thigh with complete transection of the SFA and the femoral vein came into the trauma bay. The patient was initially unstable and therefore was shunted until stabilized. Once stable that night, he was brought back to the operating room for repair. Given limited conduit available, the artery was repaired with a PTFE synthetic graft, and the vein was ligated. There was not enough time during this interval to ship a cryopreserved graft. This image shows both the artery and the vein shunted. These are the basic requirements for an on-site freezer. The space required is limited and requires liquid nitrogen tanks for use. Staff can be trained on the proper safety and maintenance protocols in order to have this freezer on site. The question, though, is there much evidence for the use of allograft in trauma situations? As of yet, there are virtually no high-powered studies that have looked into this. Most of the literature on the use of allograft is in regards to aortic graft infections. This would be interesting to study in the trauma population and understand the durability and economics of the use of allograft in this setting. In conclusion, timing is critical in vascular trauma. Immediate reconstruction of vessels seem to be the optimal treatment in patients that are stable. However, the use of autologous grafts has proven to be limited given availability, size mismatches, and increased operative times. Prosthetics have poor compatibility and frequently become thrombosed and can become infected. Having allografts on site at trauma centers enhances the surgeon's armamentarium in the effort to reduce operative and ischemic times while remaining resistant to infection. Thank you.